Well, in the interest of time, since we have such a busy schedule today and a lot to present, I think we're going to go ahead and get started. I'd like to welcome you to the Breast Cancer Gaps Project Lesson Learned webinar. I'm Chris Newcomer.
Where'd you get them at?
And if I could ask you all to please mute, that would be lovely. I'm Chris Newcomer. I'm one of the project directors, and we are delighted to share this information with you today on behalf of the GAPS Project Community Co-Design Team, many of whom are presenting and present today. My passion for this project started when I became a member of Minnesota Cancer Alliance, most recently serving as chair of the statewide collaboration to reduce the burden of cancer for all Minnesotans. Equal access to screening and care is critical to the health of every community in our state. Now, I'd just like to go over a couple of guidelines for today. Please make sure you are muted. We will use the chat for any comments or questions. At the end, we hope to be able to answer a few questions from the chat. In the limited time we have, if you have a question that wasn't answered in the webinar, look for our contact information in the email you received later this week. That email will also include the webinar recording, lessons learned PowerPoint, and a GAPS interest survey. Pat, your turn.
Okay, welcome to each of you, and thanks a lot, Chris. Today, you'll get to meet some members of the GAPS Community Co-Design Team. You'll view the prototype videos and hear about their lessons. And you may even discover some opportunities to be engaged as the project moves forward. The Breast Cancer Gaps Project, affectionately known as GAPS, is highly collaborative, and it's driven by the lived experience of the Black community. As project directors, Chris and I empower and guide others to partner and produce results. We definitely do not own this work. It's owned by the community and healthcare systems, connecting with each other. A quick note before we dive in. 2 weeks ago, I had a very unexpected major surgery on my face. So my video will not be on during the webinar. And this, trust me, this is a good thing. That said, as a public health consultant for 25 years and a 19-year breast cancer survivor, my passion is to help launch projects like this one that are inspired, led by, and sustained by the community. So let's talk about the GAPS project. Next slide. Why are we here? 41%. Black women have a 41% greater breast cancer mortality than white women. That number is absolutely horrifying. We can't ignore it. It's just plain unacceptable, and it spurs the call to action to achieve the Breast Cancer Gaps purpose. And this is the existing purpose of the GAPS project. The African American community members and healthcare providers partner to create and deliver innovative breast cancer screening prototypes using a community co-design model. Next slide. What are the values that this project lives by? There's 3 key values. The first is that we focus on the lived experiences of Black women who are most impacted by breast cancer. The second value is creating an equitable, inclusive, and transparent process that leverages collective creativity and is inspired, led by, and sustained by Black women. And third is about being action-focused by creating iterative prototypes that allow for feedback and insights in real time to inform and refine the work. It's interesting, the GAPS guiding principles are the heart of the work, and they've been expressed throughout the project. They are living. What they're not is a written list on a flip chart or a whiteboard at the first meeting, never to be seen again. This is a good lesson for us to keep the values alive. Next slide. The GAPS project has 3 phases so far. The first phase began in May 2021, and with phase 3 is going to be completed at the end of this month. You'll hear about phases 4 and 5 later in the webinar. So in the first phase, a group brainstormed gaps across the breast cancer continuum of care for women. Well, that was all fine, but we had to test that. So we tested the assumptions in phase 1, and guess what? Got a reality check in phase 2, wherein we surveyed Black women and healthcare providers about needs and solutions to getting mammograms and breast cancer care. The third phase, which we are just finishing, is to use a community co-design model with sprint sessions to create prototypes and learnings. And what that is design thinking. Next slide. Let's take a walk from right to left on this slide. The 4 phases succinctly defines design thinking and the phases that we went through with the community co-design model. The first phase is idea generation. That's where the ideas come forward. And that idea generation isn't just from a sitting group in a room, it's from the wider community. The second phase is prototyping, which is a template or a model for the idea, for the solution to increase, how do we increase that 41% for learning purposes? So that's prototyping. Phase 3, testing and development. So you have a prototype, but you have to keep iterating it. You test it, you improve it. You look at different ideas. You say to yourself, what works, what doesn't work? And it's energetic, it's constant, and you're learning on the spot. Phase 4, roll out and diffusion, and that's rolling out the promising innovations either inside or outside the organization. And what we're doing today is showing you what the tested models look like. So I'd like to talk a little bit more about design thinking. It's kind of a challenge to try to describe design thinking in one slide, but I'm gonna give it a shot. The first check mark, do then think. Design thinking moves us from traditional thinking to do approach to a doing to think practice. You know what? Since grade school, we've been trained to think to do, which is typically how strategic planning and project management have been done. In design thinking, it switches to do and then think through the 4 phases we just walked through. Typically, design thinking projects are small scopes. The idea is to build on what happens in these prototypes, to listen, really listen with empathy, and to learn from them. Why? So you can make a decision if you want to preserve what's happening in the prototype or you want to pivot. And if you pivot and you keep moving and looking at improving it, you're able to make transformative changes as you go. But that is, like I said, the Cliff Note version of design thinking. Now I'm very excited to call on Chris because we're going to show you some of the prototypes.
After the 2 different approaches.
Thank you, Pat. All of our prototypes that we created were based on the work of the co-design team. They looked at information, data, research, and had many community conversations to develop these 3 prototype areas. The first prototype that we created, or they recommended we do and try, was awareness of the issue by making, and we thought we'd do that by making 4 short videos asking women to get screened. A lot of conversation in our sprint sessions were about the education on the myths, the mammogram process, and breast health. How can we do something to address that? Both these sets of videos are available for you anytime on YouTube, but we also want to tell you that we can make changes in the videos and add your logo to the videos if you would like to be using them in your system, in your community, in your clinic. The last one was the community front door concept. We all agreed that the front door for the community is not the door of the hospital, but it's really the front door of engaging women on the need for screening in the community from trusted sources. We've started to work on that. This is one we did a little pivoting on, and we will be working more on it in phase 4. So now I'd like to show you one of the awareness videos.
So after finding out that there is this extraordinary gap of Black women dying from breast cancer, I thought to myself, what can I do to help? And so this is one of those things where I'm asking you to go get screened, because I matter, you matter, we matter. Had I not gotten screened, I would not be here today. I was diagnosed with breast cancer 2 years ago, putting on a sports bra. And because I had great access to health care, I was able to be screened. And as I went through treatment, I thought to myself, I don't see a lot of women who look like me, a lot of Black women. And that gap rose high and strong when I was getting treatment. And to me, it seemed that either we aren't getting screened or we don't have access to care, and neither one of those things are acceptable. I matter, you matter, we matter. Please go get screened. Thank you.
So that at the end was just an example of how we can make some of these look and have your comments on the end with your logo. Otherwise, they're just the end. I would like to introduce now, next slide, one of the women who did a video for us and has been part of this co-design team and an integral part of this. Her name is Whitney Terrell, and she helps Minnesotans living with disabilities access home care, home and community-based services through her role at the Minnesota Department of Human Services. She also leverages poetry and storytelling to start important conversations about social justice. Whitney?
Hi, good afternoon, everyone. I'm really been very excited to have been a part of this project. Raising awareness, especially to share my grandmother's story through this experience has been very powerful for me. So I want to thank the whole team and the GAPS project who's helped bring this forward. One of the most important things that I've found is like the co-creation process and collecting stories really helped us to feel connected. Can you hear me okay?
Yes.
Okay.
Yes.
Yeah, to feel connected and to build community even through our project team. So in sharing my story, I really had the intention of making sure that the really powerful impact that my grandmother has had in my life was really honored. And so I think that having this opportunity has been really important, both to promote health equity and then also to really center the needs of African-American women in dealing with breast cancer. So screening and working towards having that opportunity really starts, I think, through a lot of like trusted relationships. Wanting to uphold those really important and powerful relationships that have shaped my life. And so when I've worked to go, you know, whether I'm engaging with other Black women through groups that we have ongoing or even just talking to my own relatives, it's been really important to be a part of collecting those stories, to see them filtered into a really important campaign. So I feel really privileged to be a part of it, and I hope that a lot of people will continue to, share the videos, share the campaign, and also understand the experiences that are impacting how Black women are getting access to screening opportunities.
You're muted, Chris.
Thanks, Whitney. I really appreciate you sharing that with you. This group, as you met 4 times for 2 hours each and had work in between over the summer. So we had a huge sense of commitment from our women on our team. Next slide, please. During this time, we also ran a digital meeting testing. We used Dynasty Media, which is part of the Minneapolis Spokesman and Recorder. We had them do some media testing with our videos to see what resonated, what didn't work, what worked. And it ran in early October, during October and early November. And one of the lessons learned I want to highlight is actually helping inform one of our new prototypes that we're working on, the role of men in women's health. As you can see, 51% of the video viewers of these videos were men. So that is one of our learnings and one of the things we're going to be working on going forward. Now I'd like to show you a sample of our breast education work. Next slide.
I've been helping women get mammograms for almost 10 years now. The process is pretty simple. It takes about 30 minutes in and out. My name is Natasha Hollowell, and I'm here to talk you through the mammogram. So the check-in process is pretty much the same as any other appointment. You go into the clinic, you check in at the desk. They may ask for your ID and your insurance card. They may even have you fill out a few forms. If you don't have insurance, that's okay. There's a program named Sage that can help you with that. They'll have you have a seat in the lobby, then a nurse or a tech will come out and call your name. Once the nurse or the tech grabs you from the lobby, they'll take you back to a private room, give you a robe, give you time to undress from the waist up. Once you're ready, they will take you to the screening room. And on the way to the screening room, you can ask them any questions you may have. They're happy to answer those for you. Once you're in the screening room, the tech will walk you up to the machine. They will help you to position your breasts on the machine. Yes, this is a little uncomfortable or a little weird, but it's okay. The techs have seen everything. They've seen all shapes and sizes, and they will make sure that you're comfortable. Once they have you positioned on the machine in the correct way, they will take a couple images. They take up to about 4 images per breast. They will check those images. Everything looks okay, then you're good to go. Once the screening is done, the tech will take you back to the dressing room to get dressed. Once you're dressed, if anything is needed, they will have you stop at the front desk. If not, you're free to go. You should receive results within 2 days via email or an app. If there is something else that needs to be done, you will receive a phone call for scheduling. So the process is pretty simple. You can have a mammogram any day of the week, and you don't need a referral for it. So if you're over 40, please get a mammogram. You matter, I matter, we all matter too much not to be screened.
That was Natasha Hollowell, who is on our team, who is also on our team. And believe it or not, the woman in the video was her sister, Casey, who had just had her mammogram. And so she offered to be our actress in this. I'd like to now introduce, can I have the next slide, please? I'd like to now introduce 2 women who were on our team. Dr. Lashonda Soma. She is a radiologist specializing in breast cancer at Regents Hospital, and Paula Indahar, a senior clinic manager at Health Partners. Paula and Lashonda.
Hi, guys. When I first met Chris and was asked to be part of this project, I was so thrilled, and I'm also really, really excited to see so many people on this webinar today that are interested in this topic. One of the things that was very apparent through the first stages of this project was how many misconceptions and the myths that are out there around getting a mammogram, how, when, where, and also about breast health in general. And so it was very important for me to be a part of helping to educate women about what to expect, what to worry about, what not to worry about. When you start from a place of distrust already, when reality doesn't meet your expectations, you're that much closer to just completely disengaging. And I feel like that probably happens a lot in the Black community, where having a situation where something happened that you didn't expect, or you felt like things were dismissed, instead of having, being able to advocate and re-engage at another location or with another provider, you're more likely to withdraw, and withdrawing can cost you your life. So what we were really focused on is trying to get some good education out there so women can understand their breasts and about what needs to be evaluated, what is okay, encourage them to come in and get their screening, and to help them understand what that'll entail so that they have as much information coming into the situation as possible, and that would decrease their fear around getting mammograms and what may ensue from there. So it's been very exciting to be a part of this project. These videos have been amazing, and I think many women could benefit from them. And I'm so excited to see whether they can help close the gap. So thank you, guys.
Hi, and I'm Paula, and I just want to say that it was an honor to be part of this project, and I was thinking from a system perspective. And so just wanted to kind of share with you some of the challenges from a system perspective on implementing these prototypes that I kind of have found. I come from a large organization, and we have many competing initiatives that can slow down the delivery of the information to our patients. The second one was really for any technical changes, such as adding videos to electronic messages. We must have buy-in from our leaders, which is not so much of a challenge as securing the resources to help us implement those changes to any current processes that we have. And these resources are generally allocated to other projects. The third thing was determining the most effective ways to provide the education to our patients and the community, such as direct messaging to our existing patients through email, but also looking beyond our patients and providing it for the communities through maybe some social media, television, or radio. Another challenge, our fourth challenge that I feel we had is with the healthcare staffing shortages today, it's challenging acquiring our mammography staff. We'd like to offer more access on weekends and evenings. Some women prefer those times so that it won't interfere with their work. And then the fifth one was our marketing plans in our organization are determined early in the year. So it can be a challenge to pivot in larger systems of already approved plans. Just wanted to also share with you some advantages of a system working with the community design project. One for me was having the community to connect with having the opportunity to connect with these women in the community, to really listen and hear from these women what their barriers are and not making assumptions of what I think their barriers are. And then the women involved in this project are passionate about reducing the mortality rate and getting African American women screened for breast cancer. That passion shows in those videos that were produced through this project. And I'm very grateful that we might be able to use those. I do have one question for you. If you've been involved in any community design thinking projects, what disadvantages or advantages did you discover in this work? If you have a moment, please type that in the chat. And I appreciate it. Thank you.
Thanks, Paula and LaShonda. I really appreciate your insights on this. I want to come back and tell you that LaShonda herself made 2 of our education videos. One is on myth busting and the other one is on breast health. All of these are available on our YouTube channel. And if you just go to YouTube and Google Breast Cancer Gaps Project, you should come to our page. We will have a link later in the program. I would like to now turn this over to Pat to talk a little bit about other lessons learned. Next slide.
Thanks, Chris. First of all, gratitude from me as well to Whitney, Paula, and LaShonda. Thank you. Chris and I would like to convey some other lessons that we learned. And we're just going to do this rather spontaneously. Don't need to take notes because we'll send out a document of lessons learned after the webinar. I'll start with some insights. In doing design thinking, I really view that as an effective way of thinking for this project. The community co-design team had iterative conversations with the community and with each other. And those conversations included strong empathy, creativity, and some challenging of assumptions and mindsets. This led to the design and testing of the prototypes. So a lot of it was about that energy. A second lesson for me is to be intentional about finding the right leadership and a diverse mix of members and talents and give it the time it needs. It's interesting, sometimes we don't give enough time to that, and that's where we should spend a lot of our time. Third, another lesson is to really understand that clinics and systems have different ways of operating when they make change. For example, using the videos in patient emails or portals to drive screening appointments. The fourth lesson was to, Chris mentioned this, to have open access to all the videos and the ability to brand them for your organization. It's important not for just health systems, but for community groups. And last but never least is always hold the community voices and the guiding principles as the heart and the soul of the work. Chris, want to add some lessons?
Yes, I do. One of the things that became very apparent to Pat and I early on is that we needed to be very clear with our external partners and sponsors of the role of Pat and I as white project managers. The ownership of this work lies in the community, needs to lie in the community. Letting team members and the community know our role really helps them take ownership. The other thing, as much as you outline a prototype, the nature of the process will be different. What you actually execute will look different. It's really hard for a lot of people to live in chaos or what I call gray, but you really need to live in gray as you do prototyping. The other one is don't assume your messages will get shared, that people will think they're so amazing that they'll just share them all over the place. Have an actual marketing plan to share the messages. Also, make sure you have a place for people to go and learn about the project. We ended up building a small website, so we at least had a landing page for people to get information. As you saw in the videos, personal stories are critical to video viewership. When we did the digital study, one of the comments was they were so approachable and kind when the women who were looking at them. The last one is really make sure that the actors are women from the community. They need to be people that they might run into at the grocery store or at church. It really needs to be about community and people in the community doing this work. Some of these lessons will be new to you, but some of them also may already be known. That's where we've been. Now, where are we going? What does our future look like? Next slide. So believe it or not, we have already outlined gaps phases 4 and 5. We want to use the community co-design to ensure that this movement of We Matter is community inspired and led. Some of our prototypes are partnerships with Black community networks and health systems, the Men Matter 2 co-design. We'd like to do a community party, not a health fair, called Live, Laugh, and Learn. And we'll talk about movement building and infrastructure. A lot of this wouldn't be happening without the help of Blue Cross Blue Shield, who is committed to addressing racial and health equity issues in our state. The co-design team believes that the GAPS project should and will evolve into the We Matter movement. So Pat, you want to talk a little bit about the We Matter movement?
Okay, next slide, please. Imagine this vision with me, this movement building vision. Let's say that the threads you see are disparate networks within the Black community. And these networks are asking their members to tell a friend to get a mammogram, to get screened. What happens when these individual networks all connect with each other? What happens if these individual networks light up? What happens is you have a We Matter movement, quite simply. And that's the vision. So a definition of a movement is, one definition is that it's a coalition of the willing. A movement is a loosely organized but sustained campaign supporting a social goal. And typically it's focused on a change in society's structures, actions, or values. The next slide. Here's some initial hopes for the We Matter movement, is that this movement, as it grows and ripples throughout the community, will be owned and run by the Black community, a community tailored with its own identity. And it'll be about ongoing year-round work, not just in October, and that the We Matter movement will choose its own leadership and its own structure. And that's the vision for the We Matter movement. I think that Chris mentioned a bit ago about living in chaos or living in the gray. And that's one of the big lessons for the project. And I think that's going to be there for a while, because the bottom line is this: with the movement building, the We Matter movement won't be a right-brained linear process. I imagine it'll look energizing, messy, and it'll take a lot of detours, and it'll be community created and also embraced. So that, again, is the vision. And we'd like to now have Chris introduce our final video and a final speaker. Chris?
Thanks, Pat. I just want to add that because of what we have in funding, this is a 2-year project, and we really want to start thinking about how does the community create this movement around not only breast cancer for Black women, but possibly other health disparity areas. It's a really exciting time, and the comment or the topic of We Matter was actually the decision of the community co-design team that term We Matter resonated with them. So that's why the transition to the We Matter movement. So
Chris, it also means that Chris and I, that our goal is to phase ourselves out of the project and hand the ownership to the community.
Yes, it does. So I'd like to show you another video that was done as part of our awareness video. We did have 3 videos done that were in a studio, and then our friend Pat Leonard, who I had met when she was a Firefly sister and is a mentor for women with breast cancer, did her own in her home. And so the idea is these videos do not have to be produced, but they have to be stories. So if we could show the next video.
Hi, I just want to share with you my story and statistics that I found that Black women with breast cancer are 41% more likely to die than white women. I just want to acknowledge that I am a 7-year breast cancer survivor this year. If it wasn't for my early detections and my annual mammograms, I would not maybe have a different story at this time. But I want to say that through successful treatments of radiation and family support and good friends, I am a 7-year survivor and I am proud to announce that. My son's number one goal for me was, Mom, this is a quiz of God testing your faith. So, ladies, please get checked out. Men, please get checked out. And as one of the receptionists said to me in the Hope Chest Clinic, I've got another chance, a second chance at life. Not only make it your second chance if you've been diagnosed, but make it a chance for everyone to enjoy and love on you more. Thank you.
So all of this really, as we go forward, talks about inclusive community engagement. And we just wanted to show you a little bit about the 4 components of community co-design. The first one is humility and inclusivity. The second is leverage assets. Third one is radical collaboration, diversity of ideas. And the fourth one is to be action focused. We started doing this work with our team in May, and here we are showing the fruits of our labor in February. I'd like to ask LaShonda back to talk a little bit about her sense of being on this committee and the sense of how this process felt for her and I think for the other women on the committee. LaShonda?
Hi again, guys. Yeah, so if I had to wrap this project up in one word, I would say it was fun. It was just so exciting to be working with people with a shared goal. Sometimes when you're working on a project, you have people that just need to be involved and not necessarily people that was their passion as well. So it was just a lot of fun to talk to women who were just as interested in this topic as I was. The other cool thing about the project was that it was action focused. It's kind of my mantra in life and at work, which is do something, get as much information as you can quickly, make a decision, do something, and then tweak it, because otherwise you get paralysis of the analysis. You're sharpshooting ideas that probably should have been given more of an opportunity. And I just love the fact that we were able to feel that this was in reach because it didn't have to go through a lot of red tape. And so it doesn't give people time to lose their passion. You can see things happening and then you can pivot. Hey, we didn't expect this, or hey, what about that? Let's try that. That was so refreshing. I'm sure if you work in a large institution, you know what it's like to be caught in the red tape. And so it was just very exciting to be able to work in this project, and also to see how many things we had in common as experiences, but also how many things were still varied between us, and how important it is not to see Black people, Black women as a monolith, but to also still recognize that there are so many things that are different between us, and the value that we each bring from our own personal experiences into our communities. And where we may be able to connect with one person, we may not connect with someone else. And that's why it takes all of us contributing. So this project was great. And it's just the kind of work that I'd love to continue spending my free time doing. So thanks to Pat and Chris for putting it together, and very excited to see where it goes next.
Thanks, LaShonda. We loved working with you too. And you're a great storyteller. Pat and I, we want to, next slide, please. We want to review a couple things, some options for engagement that you can have, and also just some of our final thoughts about this. As we grow this project, this prototyping and the Men Matter and our network building, there are some things that you can be involved with. The one of them is the use and awareness of our educational videos. The YouTube channel is there, and I'm also trying to get it in the link. So you can go to it, but you could just go to YouTube and Google breastcancergaps.org and it would probably show up. We are going to be building a co-design team for Men Matter, needing 5 to 6 men from the community, different ages and different life experiences, to talk about how they could impact the lives of their spouses or partners. As we roll out our third prototype that we didn't get to well enough to be able to present is our network building prototype. It is the idea of can we create networks? Can we do a front door to Black women's networks to talk about tell a friend and we matter, whether it's your church group or your sorority or something like that. We want to look at how we can do that network building within the Black female community. We are going to be having in October a first annual Live, Laugh, and Learn event. It is not going to be a health fair. It's going to be a party. And a party with screening and fun and great speakers sometime the end of September. Love to have people a part of that. And the last one is really helping us with this movement development, whether it's just telling a friend or finding a group that we should be in contact with or present to. Those are really the options for engagement. And as you see, our emails are on there. You will be getting this PowerPoint, a survey with options for engagement, the recording by this Friday. So don't worry about it. We will be sending all of this out. So Pat, anything else? I know you have some questions or a question, and then we will be able to answer some of yours.
Thank you. I also want to point out that the YouTube channel is in the chat. Thanks, David. So in addition to being on the slide, what I'd like to do before we part, I'd like to invite each of you to enter your response to this question I'm going to ask you into the chat. I think that would be so immensely helpful for the team and for us. And this is the question. Let me warn you, I'm going to give you 40 seconds to type in your response. The question is, what is the most important thing that you're taking away from this webinar? Okay, 40 seconds. Thanks. Okay, 40 seconds. Chris, I have you commented on this as well.
I'm sorry, Pat, what was that?
I said, Chris, is there anything you'd like to respond to anything in the chat?
I think that a lot of it is around the fact that we made it of the community and also of community-based and community-owned, and that communication is more important and that we moved quickly. So those are some of the things you said. We did move quickly. We surprised ourselves and we continue to want to move quickly. So one of the questions is, how will the videos be distributed to the community? That is something we are working on in our next round of work. So we will see, we have some ideas, but we would love your ideas. So please feel free to give us a call, give us send us an email. Here's an idea you might think about. And we also want to say, when we started this work, that people said, well, how are you going to know that you're reducing the 41%? And the commitment was our proxies for reducing mortality were, if we can reduce the age of first mammogram to 40. And that if we can reduce the stage at first diagnosis, those two things will ultimately affect mortality rate. Pat, anything that you saw?
I know I would just have to reiterate what you said. And I think that the idea of having a full community embrace of this moving forward will be fun and challenging and worth it. Okay, anything else, Chris? I'll move to the next slide.
I think we're good, and we might have time for a few questions.
Let's do that now.
Okay. All right. If you unmute yourself or put your question in your chat, and we'll see if we can answer it, or I think Dr. Soma is still on the call. Paul is still on the call. So if you want to put a question for us in the chat, go right ahead.
Good afternoon. I have a question. This is Pam Mason from ACS. First, wanted to say that this work is fabulous, and just really appreciate everything that the team has done. My question is, do we know if screening appointments have been made and have people gotten screened from the videos that have been shared? Do we know if it's really creating action?
We don't know, in a data way, but we do know anecdotally. Many of our people on our team shared them with their friends, and actually they came back to us and said, 10 of my friends got screened because they saw me talk about it. So we know that there's that power of seeing somebody talking about it that can drive the screening. But there is a step in between seeing a video and making an appointment.
And also, we're also in the process of continuing to do testing with healthcare systems with the videos, and in conversations with individual healthcare systems can talk about how they would like to look at that as well.
Great, thank you both.
Yeah. So Kelly Hughes had a question. What about disparities in healthcare after screening, which we all agree is an issue. When we went into this project, our mantra was we can't boil the ocean. So we had to focus on it really down on where we can start to make some difference and move this information and learn to go into the next level, which is the disparities after screening. So that was an intentional choice of all the people who started with us on the GAPS project and the community co-design people. We just had to start somewhere. Pat, anything else you want to add about that?
Oh, I'm good.
Okay. Any other?
Chris, I do have one thing that I realized because we wanted to be concise. But when we did the survey as part of phase 2 of this project, the question was, what is stopping women from getting mammograms? What are the reasons, and what are Black women saying about that? And the 3 general categories that the prototypes are actually based on because of this is the first and most important was fear. The second was the lack of sense of urgency. And the third was not having a lot of information. So if you have mammogram techs with patients coming in who don't know what a mammogram is, that helped generate the video, one of the videos that you saw today. So I just wanted to share that too, Chris.
So it looks like Hazel Tanner has her hand up. Hazel, did you have a question?
I do, because I guess I've been in the game for a long time. And I think it's important that, I know you said you had to pick your priorities, but it kind of goes hand in hand for follow-up in healthcare once they have the mammogram. So just to have the test and then don't have adequate care afterwards is a disservice to the woman. So you're going to have people saying, I don't need to go because I'm not going to get the care I need. So we're faced with a double jeopardy there. So you did say you had Blue Cross Blue Shield that was assisting in this program, right?
Yes.
So they're a major health insurance provider. So I don't understand why they are not being trained and taught about the disparity. I mean, they are, I'm assuming that they don't know what they don't know. Okay, so to decrease the disparities, that they should be working top with the top guns to try and decrease it. And then if they're doing it, then let's go to Health Partners and Align Health and the rest of them. I mean, so I think this needs to be go hand in hand. I don't think it's a either or. It has to be an and not either or.
We appreciate that, Hazel. I think that's really important. We are trying to do some work with the Minnesota Council of Health Plans and other organizations in a much broader way. But part of what we needed to do was to start some momentum. And now that next area can be addressed as we go forward.
I understand that. And like I said, I've been a nurse since 1967. Okay. And I've been hearing this singing song and dance for too long. They're making it's an either or project. It cannot maintain that same status along. If you keep doing the same thing, you're going to keep getting the same results. So it has to go along together. I mean, if you're going to do the mammogram, then the resources have to be available for the clients to go in to get the resources that they need to make sure that they catch it in time and do the necessary healthcare follow-up at the same time. We can't put it off. We just cannot do that anymore. We can't keep doing the same thing, expect a different outcome.
Well, Hazel, I would like possibly if I could reach out to you and we could have a deeper conversation around this. And I noticed that AABCA also piped in to see how we could include the next step into some of our work. Would you be open to that?
I would, because I'm tired of hearing the same song and dance. I really am. I mean, I've been a nurse too long and it's the same thing. You can expect a different outcome and it's not going to happen. You keep getting what you get.
Okay. Well, I will definitely personally reach out to you and we can have more of this conversation in depth.
All righty.
Any
So
other?
Chris, there was a comment in the chat from Riona about that this is affirming that this is true about Black women and cancer. And she mentioned that the African American Breast Cancer Alliance has been dealing with this for 32 years. And so that just the whole thing about having action.
Thank you very much.
Okay. Any other questions? We'd like to thank you all for coming. Could we have the next slide, please?
I made sure that this slide was big. And I wanted to talk about gratitude. Chris mentioned it before, but I also want to point out Blue Cross Blue Shield of Minnesota has a strategic commitment to addressing racial health inequities, and that they provided initial funding for the GAPS Phase 3. And because of that, we had the opportunity to connect with the community clinics and system, as we've described, to test these new ideas for change. So thank you very much. Also, I'm going to mention the GAPS initiative received financial support from NIH via the University of Minnesota's Clinical Translational Medicine Institute, which I practice saying. And so gratitude there as well. Chris, next slide.
Well, I want to thank you all for attending today and helping build a movement to change that 41% statistic for Black women. That mortality rate is unacceptable. Pat?
I'd like to also thank our community co-design team members who spoke today and were so active in the past year. It has been an honor to walk beside you. So thank you everyone for joining us. Have a great afternoon.